again for giving me this opportunity to give an update. So actually not really an orientation because we are on our 5th month of the pandemic, and I'm sure that all of us here are overloaded with many information about the disease. So I will just be giving an update on COVID-19, the pandemic. So again, I would like to thank Ospital ng Maynila Medical Center for giving me this opportunity to share the updates about the disease. Special mention to our beloved department, the Department of Medicine. So for this morning, here are my objectives. Again, I will just run through the epidemiology of COVID-19. So just a background, how it started and up to the present condition. So what's the mode of transmission of the virus, the available diagnostic tests, and mainly I'll be focusing on the infection prevention and control measures for COVID-19, which is very important and applicable to our hospital. So just a background, so it was last day of 2019 when there were reports of pneumonia of unidentified cause in Wuhan, China. Okay, so with 44 cases, patients with pneumonia of unknown etiology. So they found out that those with unknown etiology of pneumonia, those patients with this unknown etiology of pneumonia were associated or were linked to being at a Huanan seafood market in Wuhan, China. Thus, it was closed during that time. First day of the year, so January 1, 2020. 11 days after, there was a report already of a first fatal case of first mortality secondary to unknown etiology. And eventually, from China, they submitted the genome and to the World Health Organization, and the World Health Organization was able to sequence the genome of the said novel virus, and thus named it initially as 2019 nCoV, or 2019 novel coronavirus. So around 2 weeks after, okay, first 2 weeks of the year, so there were reports already of cases of still unknown pneumonia, reports aside or outside China. So there were reports of this pneumonia in Thailand already, okay, in Japan, and even in North Korea. So in January 21, 2020, there was the first confirmed case in the United States. And during this time also, we had our first PUI. So during that time, still call it as person under investigation or PUI, reported in Cebu. However, it was eventually classified as non-2019 nCoV. So January 29, 2020, there were still no confirmed case in the country until, okay, in January 30, we had our first report of first confirmed case of 2019 nCoV in the Philippines, followed by a second case in February 20, 2020, and eventually a third case. From then on, so as what they say, the rest is history. Okay, because as of now, so to date, August 11, 2020, there were 20 million confirmed cases, more than 20 million of confirmed COVID cases worldwide, with around 739,526 deaths, or around 3 to 4% mortality rate. In the Philippines, we had total reports of more than 100,000 cases in the country, with the highest reported daily confirmed case last August 10 of around 6,958 confirmed COVID case. Okay. So just a backtrack again, it was in February 11, 2020, when the World Health Organization identified that it was a new or a novel disease called COVID-19 or coronavirus disease 19, secondary to a new and novel virus also named the severe acute respiratory syndrome coronavirus 2. So this is to differentiate from the first severe acute respiratory syndrome coronavirus, which is the etiologic agent of SARS identified in 2002. So 1 month after, in March 11, 2020, again, it was declared already as a pandemic because of a worldwide distribution of the disease and the morbidity and mortality associated with it. As I've said, as of yesterday, there were around 20 million cases of confirmed COVID case worldwide. Okay, so just a just to mention the etiologic agent of the disease. So again, it's secondary to a virus. COVID-19 is secondary to an RNA virus belonging to coronavirus family. So it's SARS-CoV-2. Okay, before it was called as nCoV only, nCoV 2019 or novel coronavirus 2019, but it was renamed in February 11 as severe acute respiratory syndrome coronavirus 2, which is closely related to SARS-CoV of 2002 to 2003, and another closely related virus is the MERS-CoV, which is then the etiologic agent of Middle East respiratory syndrome identified in 2012. Okay, so what's the main mode of transmission of the virus? So WHO acknowledged that still the main mode of transmission of the virus is via human to human, so particularly via respiratory droplets. I'm sure we are all familiar with this mode of transmission, so but just a review for all of us. Respiratory droplets pertain to respiratory particles, fluid containing the virus, which is large enough, around 5 to 10 micrometers in diameter. So it's very important that we know the nature of these respiratory droplets, because knowing that it's large enough, so it has the tendency to fall on the ground because of the gravity, thus it cannot reach farther than 6 to 12 feet after being produced. So mainly it's produced after coughing or sneezing or even exhaling or talking only. So WHO identified that airborne transmission of SARS-CoV-2 up to this time has not clearly been documented. However, these respiratory droplets can become smaller particles and thus can produce airborne particles if aerosol generating procedures are performed. So what are these AGP or aerosol generating procedures? So whenever you do CPR or cardiopulmonary resuscitation, intubation, sputum induction, nebulization, okay, so remember these large respiratory droplets can be smaller and then can be transmitted via airborne. So there is a possibility that this virus can be transmitted via airborne, but primarily when you perform this aerosol generating procedure. So that's the evidence as of this time. Okay, so this is to differentiate the respiratory droplets again, which is large enough, 5 to 10 micrometers, as compared to your droplet nuclei, which is less than 5 micrometers. So being small, so compared to your respiratory droplet, which has tendency to fall on the ground and cannot reach farther beyond 6 to 12 feet. So this droplet nuclei produced whenever you have airborne infections can reach farther than 6 to 12 feet. So there were several studies looking on the possibility of airborne transmission of the virus. Okay, so this study compared or analyze the possibility of airborne transmission of the virus. So I just want to show everyone here that whenever there is an event of sneezing, so sneezing is a forceful expiration already. So the farthest the droplets can reach is around 6 meters, okay, as compared to your airborne, which can reach farther than that, okay. However, when you cough, so the farthest that the droplets can reach is around 3 meters. And when you exhale or ordinary talking, the farthest that the respiratory droplet can reach is around 1 meter. So this is very important to note, because this is the rationale why we advise maintaining a physical distance of at least 1 meter or more than that, okay? Because if we're talking about respiratory droplet again, so ideally or theoretically when it's respiratory droplet, with normal talking, the farthest that it can reach is around 1 meter. So if you maintain your distance more than 1 meter, then your possibility of acquiring the virus is lesser as compared when you are nearer to that possible infected person. Okay, so this figure shows that when you have an infected person here, so he or she, after sneezing or coughing, can produce all of these large droplets and aerosol cloud. However, whenever he is wearing a surgical mask, or all the more when he is wearing an N95 mask. So we can see here that the droplets produced and the aerosol cloud produced is much lesser as compared when he or she is not wearing any respirator or any protective mask. So this figure then shows if you have an infected person and then you have a susceptible host there, particularly close enough, less than 1 meter, and not wearing any mask, both the infected person and the suspected person, susceptible host, then they have all this risk or possibility of getting the virus. But then again, when the susceptible host, even if the infected person is not wearing mask, but when the susceptible host is wearing a mask, and all the more an N95, the risk of getting the virus is decreased. Okay, so thus studies summarized or concluded that still the main mode of transmission of the virus is via respiratory droplet. However, with violent and even non-violent expiration of the virus, an airborne transmission is a possibility, but still we need more experimental studies to support this. So again, what is established to date is that this respiratory droplet can be transformed into an airborne, into a droplet nuclei whenever we perform aerosol generating procedures. Okay. So aside from respiratory droplet, the other mode of transmission that WHO recognizes mode of transmission for SARS-CoV-2 is via indirect contact with contaminated surfaces. So as we can see in this figure, you have here the infected person who after sneezing or coughing, and if he or she did not perform respiratory etiquette or cough etiquette, so he or she can produce that respiratory droplet. So these respiratory droplets can land on surfaces, and if the surfaces are not properly cleaned and you touch it with your bare hands and you did not perform hand hygiene and you touch your nose, mouth, okay, and eyes, eventually it can enter your body and via nose and mouth can reach your lungs. Okay, so that's the other established mode of transmission of the virus. Okay, so several studies showed that the virus can remain viable or can maintain or can survive on inanimate surfaces such as cardboard up to 1 day, after 1 day, stainless steel up to 2 days or 48 hours, and plastic up to 72 hours or after 3 days. Okay, so this study showed that the virus can remain viable up to 2 days, ranging from 2 days to 9 days, okay, depending on the surface of the depending whether the surface is smooth or rough. Okay, so this study, we have this table showing that aside from that, the surface, the viability or the survival of the virus will also depend on the inoculum of the virus on that said surfaces. So meaning the amount of virus on that said surfaces and other environmental factors such as humidity and temperature. So this study concluded that stability and viability of the virus in inanimate surfaces or objects are influenced by temperature and relative humidity, and again, by the amount of the inoculum of the virus. Okay. So this figure summarizes the survival or the viability of the virus on different surfaces. For example, if you have a wooden table here, okay, so the virus, if you have the enough amount of the virus, can remain viable on top of that wooden table up to 4 to 5 days. If you have paper, 4 to 5 days. If you have clothes here, so 2 days. And for metals, copper, hours only. So the lesson, okay, or the message of this figure is that again, the virus can remain viable on these surfaces if not properly cleaned. Okay, so if it's not properly cleaned and if you have the enough circumstances such as enough amount and enough temperature and humidity, the virus can survive. But if these surfaces are properly cleaned and decontaminated or disinfected, we will not have a problem in the transmission of the virus. Okay, so that's the important lesson or message of this figure. Sometimes kasi, ang nag-stick lang sa mind is that these viruses can remain on the surfaces and that's it. However, we have to remember that yes, that's a possibility. These viruses can remain on the surfaces, but If these surfaces are properly cleaned and disinfected, then we will not have a problem or trouble in the transmission of the virus. Later on, I'll be discussing that part on the infection prevention and control measures for COVID-19. Okay, so how about other modes of transmission? Can the virus be transmitted via stool or other body fluids? So some studies identified SARS-CoV-2 on blood and ocular secretions. However, the role of transmission of this virus via these secretions are still not established today. So even via blood. Okay, so SARS-CoV-2 is a respiratory virus, and respiratory viruses in general are not transmitted via bloodborne. So still uncertainty on whether these viruses can be transmitted via blood. Okay, so with all of those, still WHO recommend droplet and contact precaution for SARS-CoV-2 because still the main mode of transmission of the virus is via respiratory droplet and via fomites. And again, airborne precautions are to be observed whenever a healthcare worker or whenever an aerosol generating procedure is performed, because this has the tendency to aerosolize these large respiratory droplets. Okay, so I just want to show here this figure that an infected COVID-19 patient is said to be most infectious at the time of the onset of symptoms. So half a day before the start of the symptom and during the first days of symptoms. Okay, so during the first 1 to 3 days of symptoms, okay, or during the first 1 to 3 days of illness, that's the time that an infected person is said to be most infectious or has the highest capacity to infect others, okay? Because as the symptoms go away or as the patient becomes asymptomatic, his or her infectivity also decreases. Okay, so going to the diagnostic tests for COVID-19. So currently there are 2 available tests that directly or that is specific for COVID-19. So meaning, if you want to confirm the diagnosis of COVID-19, so primarily we request for the RT-PCR or the reverse transcriptase polymerase chain reaction test. So this is the swab test that we usually request. And there is also an indirect test, antibody test, that can help in diagnosing COVID-19. So going to the first test, we have RT-PCR. So this is the gold standard for diagnosis of COVID-19. This is a test of the nucleic acid or the RNA part of the virus. It does not distinguish between infectious virus and viral genetic material remnants. So this is very important, as I will discuss later, that RT-PCR is not considered as a test of cure anymore because of this fact that it cannot distinguish an infectious virus and just remnant or a particle of the virus. So RT-PCR, just like in any other test, RT-PCR in general, not only in COVID-19, is a very sensitive test, but type of specimen can affect its sensitivity. Okay, so this figure shows the time wherein you will most likely have an RT-PCR positive result. So first week of illness, okay, even before the start of the symptom, you can start to get PCR positive test already, and up to week 1 to week 3. Because after some time, okay, the possibility that you get a positive PCR test goes down. And during the latter part of the illness, that's the time that you can utilize the antibody test already. So as I've said, the sensitivity and specificity of the RT-PCR will depend on the specimen submitted. So we can see in this table that you have an oral specimen, nasal or NP, nasopharyngeal, and we can see that nasopharyngeal swab has higher sensitivity and specificity as compared to your oropharyngeal swab, okay? But as we all know, we request for both OPS and NPS whenever RT-PCR. Okay? RT-PCR has its own advantages. So again, it is the gold standard for diagnosis. It is a known technology and a very specific test. However, it has its limitations already. So we all know this. So it is an expensive test. It's not a cheap test because it can range for between 4,000 or as high as 8,000 in different private hospitals. It is also a resource-intensive test. This is not available in all laboratories. Okay, so there are only specified subnational laboratories that can perform the test. That's why we have to wait nga for around 2 to 3 or even 4 to 5 days before we have the result. So again, this is a poor test of cure. We never use RT-PCR as a test of cure, as I mentioned. Hello?
Yes, Doktora, naririnig na po uli kayo.
So kanina, nakamute ba ako?
Yes po, Dok. Nawala po.
Since what slide soon so that I can go back?
I think yung limitations, ayan po dyan, Dok. Sa may bandang dulo po niyan.
Okay. Okay, so can I proceed?
Yes, Dok.
Thank you, Alsun. So again, RT-PCR is the gold standard for diagnosis. It's a known technology and a very specific test. However, it has its own limitations. So again, it is an expensive test, ranging from around 4,000 to 8,000 on private hospitals. It is also a resource-intensive test because not all hospitals or not all centers can perform RT-PCR for SARS-CoV-2. So that's why we have to wait nga diba? For around 2 to 3 days or 4 to 5 days before we can have the result. Again, it is a poor test of cure. We never use or we don't use now. Okay? Before kasi ginagamit. So we don't use RT-PCR now as a test of cure, as I've explained a while ago, because it cannot differentiate actual infectious viral particles versus a remnant only. That's why it's said to be a poor test of cure. And RT-PCR is a very sensitive test and is very prone, it's very specific test and is very prone to contamination. Okay, so going to the other type of diagnostic test for COVID-19, we have this antibody test. There are a lot of, there are several forms of antibody tests, but I'm sure we are all familiar with this RAT, or your rapid antibody test. Okay, so many of establishments, okay, or even in our LGUs, utilize rapid antibody tests as a diagnostic test for COVID-19. But why? Because it's a point of cure test, okay? Meaning we have the result after hours only as compared to your RT-PCR wherein we have to wait for 2 to 3 days. It's a cheap test as compared again to your RT-PCR. It costs around less than 1,000 or sometimes in private hospital, 1,800. Okay. However, the Department of Health still reminds everyone, okay, or all of us, all the more healthcare workers, that rapid antibody test is not a standalone test and should not be requested solely, okay, to confirm the diagnosis of COVID-19. Okay. So it has its own limitations. Again, it cannot diagnose early disease. Okay, as I've shown in the figure a while ago, antibodies are produced during the latter part of illness after 7 days of the illness. It's the time that the body produces antibodies already. And your antibody tests are prone to false positives, particularly in low-risk population. Thus, medical societies, PCP, PSMID, actually remind or recommend that only FDA-approved and validated rapid antibody tests should be used in conjunction or together with your swab test or your RT-PCR, and only medical doctors can prescribe and interpret this rapid antibody test. Okay, so in summary, for the diagnostic tests, RT-PCR and rapid antibody tests are the two current technologies for testing COVID-19. Each has its own advantages and disadvantages and limitations. Thus, it warrants clinical judgment for the diagnosis and eventually proper management of the issue. So speaking of management, so this is one of the most common questions that I receive or we receive. How about if we live with a close contact or a suspect, probable, or confirmed COVID-19 case? So what should be done? So I always advise that whenever we have this scenario, the best way or the best approach is to seek medical consultation, because the condition or the situation will depend on different circumstances. So either you will be advised to be admitted if you have the symptoms, okay, or only just home quarantine, even if you are COVID positive, but it's not showing any symptom. But what is established is that all symptomatic patients who are close contact, for example, if you have a household who happen to be symptomatic already, then the recommendation is to subject that person to undergo confirmatory test, and confirmatory test I am pertaining to swab test or your RT-PCR. Speaking of contact, minsan kasi doon nagkaka-problema eh. So I am a contact, but we have to define close contact, okay, so that we will not be parang anxious all the time. Okay, so according to DOH, okay, PSMID, PCCP, a close contact are those persons who experience any one of the following exposures during 2 days before and then 14 days after the onset of symptoms of whether a probable or a confirmed COVID case. And again, a close contact is defined as any of the following. So you have a face-to-face contact with a probable or a confirmed case within 1 meter or shorter, and for more than 15 minutes. So meaning if you are living in a small house, okay, if you have a household who happen to be a confirmed COVID-19 and you are living with him or her, okay, for more than 15 minutes, you stay with him or her, then you are considered as a close contact already. If you have a direct physical contact with a probable or a confirmed case, and if you render care, direct care for a patient with a probable or confirmed COVID-19 disease without proper PPE. Kasi I have to emphasize here without proper PPE, because all of us who take care of COVID-19 patient, okay, if they are not wearing proper PPE, then we are considered as a close contact already. Okay, but if we are wearing appropriate PPE, there should be no problem with that. Okay, so I just want to show here the recommendation. This is one of the most common questions also. So kapag, for example, you fulfill those close contact categories, so unfortunately you were exposed, you have an established exposure, close contact with a confirmed case, and you're not wearing proper PPE. So when should you do, okay, whenever you want to do an RT-PCR? So when should it be done? Okay, so again, we are reminded that the sensitivity of the swab test is affected by the timing of collection and the amount of virus in your body. Okay, so kung ngayon kayo na-exposure, tomorrow gusto niyo na magpa-test, so it's not highly recommended, because more or less it will turn out to be false negative. Example, okay, so you will not have an accurate result. So it's mainly recommended that you repeat or you test yourself whenever you are symptomatic. Yun naman kasi talagang recommendation eh. So whenever you are symptomatic, okay, that's the best time that you can get the best result or the accurate result of your RT-PCR. So the best time is to test during the 1st to 3rd day of symptom onset. So we can see here at day 5 of exposure, for example, you develop symptoms already, you have 62% chance of getting a correct RT-PCR result. And at day 8 of exposure, 3rd day of symptoms, for example, you develop symptoms, you have 80% chance of getting the correct RT-PCRs. Okay, so that's house, okay, at home. How about at workplace? So if you have an employee or a coworker who still, who happens to be a close contact or a suspect, probable or confirmed COVID-19 case, so the same scenario will apply as to that of a household, okay, household members. Again, at workplace, ito lang, I have to emphasize, do not panic kasi minsan that's a cause of panic already, and sometimes, unfortunately, that becomes so stigmatizing to the possible, probable, or confirmed COVID-19 case. So we have to isolate, for example, that coworker that you are suspecting to be a COVID-19 case, and then refer immediately to your company, or your office physician. And then again, same as with that of a household member, follow the medical advice whether to admit or to just do home quarantine. And again, if the close contact happens to be become symptomatic, then the recommendation is to do an RT-PCR, okay, or a swab test. Okay, so to summarize, okay, so particularly for at workplace, we have to screen everyone for symptoms. So this is the first step but very important test so as to avoid us any panic at workplace. Okay? Diba? Usong-uso na ngayon yung mga screening form, kahit nga sa mga restaurants or when we go inside the mall, we have to fill up this screening form, okay, triage form, because the dictum now is whenever we capture a symptomatic patient, okay, we have to rule out COVID-19. Okay, so whenever we have that index case or a suspect, so we have to test and isolate again with RT-PCR and perform universal infection precautions and maintain this what we call as minimum public health measure of physical distancing, universal masking, hand hygiene, and cough etiquette. Okay. So how about, that's for isolation. How about we want to discontinue? I think this is very important. When to discontinue the isolation precaution and when can the patient or the infected person can rejoin the community, okay? This is the latest recommendation by the DOH, PC Smith, as we move towards the time-based and symptom-based strategy for clearing patients. So before, we're highly reliant on the test base, as I've said a while ago. Before, during the first months of the pandemic, we require 2 negative RT-PCR before we can clear or discharge the patient or we can clear him to go back to work. But now, we're moving towards time-based and the symptom-based strategy, and these are the recommendations. So for COVID-19 confirmed symptomatic, so classified originally or initially as severe or critical, the recommendation is to wait for 21 days after the first symptom, plus at least 3 days without symptoms. Okay, so from the first day, for example, the patient becomes symptomatic, August 1, and then we clear the patient on August 21. After August 21, until August 21, he remained asymptomatic, particularly for at least 3 days, then you can send the patient home or you can clear the patient for going back or returning to work already. Again, I want to emphasize here that there is no need for a repeat RT-PCR at the end of quarantine as long as the patient is asymptomatic throughout the quarantine period. How about if the patient is COVID-19 and is classified as mild to moderate only? So particularly those mild COVID-19 patients who underwent home quarantine, when can you remove, okay, the isolation or symptom-based, discontinue the isolation and rejoin the patient to the community? So their requirement or the recommendation is 14 days after the symptom onset, so 2 weeks, but at least 3 days without symptoms. Again, no need for a repeat PCR as long as you can ensure that the patient has been asymptomatic for the past 2 weeks, particularly for the past 3 days, for 3 consecutive days. How about for asymptomatic? So kung asymptomatic, wala tayong pagbabasihan ng first day of onset of symptom. So we refer to time-based. So we wait for 14 days after the time the patient tested positive for COVID-19. So take note, swab time or swab date and not the date wherein the swab was released. Okay? magkaiba kasi yun. So there is a delay with the swab result, minsan 3 to 4 days. But we have to count the time that the swab was submitted. So again, no need for repeat COVID-19 PCR test unless if we're dealing with immunocompromised patients. So malignancy patient, those with HIV or uncontrolled diabetes or even hemodialysis patients. So we have to request for a repeat PCR before we can clear the patient. Okay, so this is an update coming from the Department of Health, PCP and PSMID, just finalized last week. Okay, so I've discussed the transmission, the diagnostic tests available, and some management for COVID-19. How about the infection prevention and control strategies in the context of COVID-19? Okay, so according to WHO, there are 3 C's for COVID-19 or 3 high-risk areas for COVID-19. So namely, so when you stay in closed spaces with insufficient ventilation, when you stay in crowded conditions with people, and when you converse in short distance. So all of these can be understood if we understood the mode of transmission of the virus. Again, when you stay in crowded condition wherein you cannot maintain physical distancing, okay, you converse in short distance, and when you have insufficient ventilation, those are the 3 higher risk areas for COVID-19. So IPC in general has these strategies: so early recognition and isolation of the etiologic agent, standard measures. That's why we always hear standard precaution. We always order sa chart standard precaution and specific infection prevention and control measures. So these IPC strategies are complemented by what we call as the engineering and the administrative controls. So this is a general hierarchy of controls, not only for COVID-19, but hierarchy of controls in general. As we can see, on the topmost part of the hierarchy is we have the elimination. Of course, if we do not have the virus, for example, that's the best way to prevent the disease. However, sometimes it's difficult to achieve this. That's why we have the other parts of the controls. So we have substitution, engineering, administrative, and as you can notice at the bottom part, lowest part of the hierarchy is actually the PPE, the use of personal protective equipment, which is one of the most commonly utilized IPC measure for COVID-19. So the NIOSH actually has this interpretation of this hierarchy of control applicable for COVID-19. So elimination is somehow equated to social isolation or what we call as physical distancing. Kaya nga, this is the rationale for the quarantine or the lockdown that we had during the first part of the pandemic, during the first months of the pandemic. Okay, because it's somehow the closest that we can give for the elimination control part of the hierarchy of control of COVID-19. Okay, then you have your substitution, engineering controls, administrative controls, and as what I've said, at the lowest part of the hierarchy is actually the PPE. So what are these engineering controls? So whenever we see these physical barriers or partitions to isolate or to separate the patient, okay, curtains in between patients, those are the engineering controls. So that's what you call as engineering control of the infection prevention and control measures. Also included in these engineering controls are the proper air handling system, the ventilation or air exchange also belongs to engineering control. As compared to your administrative controls, which include infection prevention and control policies. For example, when you make all of these policies, it's stop the patient ratio, and then triage, and then
Next.
okay. Can you hear me, Alsun?
Yes po, Doc. You are heard.
Thank you. So when we make all of these policies, wherein, for example, we have we enforce skeleton force or 1 week duty for our residents and then 1 week off. Okay, so all those policies pertain to administrative control of infection. So IPC measures for COVID-19 all start with minimizing the chance for exposures. As I've said, so screening is one of the strongest measure for us to prevent further exposure or minimize the chance of exposure to the virus. Okay, so we also have the aggressive source control. So wearing or having this policy of no face mask, no entry policy, and then implementing alternatives to face-to-face to prevent further contact, which is translated as telemedicine. Okay, so I just want to share this screening form. The Philippine College of Physicians, Philippine Society for Microbiology and Infectious Diseases, and the Philippine Hospital Infection Control Society actually drafted this guideline for the resumption of clinic at our outpatient clinics in the context of COVID-19. So we start, one of the best measure, infection control measure, is to have this screening form, again, as I've explained a while ago, to prevent or to minimize exposure to a possible COVID-19. Because we assume that if we have strict screening form, okay, then somehow we can minimize the exposure to a possible symptomatic COVID-19. So you can use this screening form, you can modify this, okay, you just check if the patient has respiratory symptoms or is experiencing fever or has this history of COVID-19 before, or a household member diagnosed with COVID-19. If any of these items, the answer is yes, then you have to refer the patient to the emergency room for further workup and to further rule out that it is not really COVID-19. So starting with your triage should have a well-ventilated triage area, again, to prevent, minimize, okay? If not prevented, minimize the transmission of the virus. So physical distancing should be maintained even at the triage area pa lang, and then we perform this minimum public health measures. So I mentioned a while ago that one way of minimizing the risk of exposure is transforming to telemedicine. So nowadays, we've shifted, okay, hindi naman all, but most of the consultation shifted to telemedicine already. So the recommendations state that face-to-face physician-patient encounters, if can be minimized, should be minimized, and telemedicine considered, particularly in patients whom the risk of getting exposed outweighs the benefit of physical encounter. So it's a fact already that if we can perform the same consultation via telemedicine as compared to that of face-to-face outpatient clinic, then we lean towards the telemedicine format, okay? And I just want to add here that if ever telemedicine will be done, we should obtain and document informed consent from the patient, because again, this is a new format of consultation in our country, relatively new. So going to other measures for minimizing the exposure, there is a no mask, no entry policy, I think, all over the country, wherever we go. So whether it's a hospital, clinic, okay, even nga sa mga malls or establishments, we advise universal masking. Okay, so before, medyo conservative pa sila, but nowadays, because of the studies shown a while ago, mask, we have to wear masks all the time, whether if you want to protect yourself and you want to prevent the transmission of the virus. So WHO released these infographics of the proper use of medical masks. So the report showed that Philippines actually is one of the, or if not the top country that follows wearing masks. However, despite of that, we have a lot of cases pa rin. Bakit? Because it showed that even if they wear masks, they are not properly wearing it. So what is important here is to emphasize the proper use of medical masks. And as we can see here, minsan alam natin but hindi na i-implement properly. So it's very important to constantly remind everyone that there is a proper way of wearing the mask. So you don't put it under your chin. It's very important that you cover both your mouth and your nose whenever you wear mask, and all the more that you don't put it just like this one, parang hinedma. Okay, so this is the improper ways of wearing or using masks. So the proper way is, for example, you're wearing an N95, your strap should not crisscross, okay? So that's the proper way of wearing an N95. And again, for surgical mask, you have to cover your nose and your mouth. And again, there's only one way of wearing a surgical mask or face mask. It doesn't matter if you are sick or you are not. Okay, so I think that is established already, and we've included that in our guidelines. So there's only one way of wearing mask. Okay, so you have the colored part, okay, outside and in white inside. Okay, and again, you have to cover your mouth and your nose. Okay, so that's for mask. How about maintaining physical distancing or social distancing? So this figure shows that spread of the virus is said to be lesser whenever you perform social distancing. And this is only not just because of, this is basically evidence-based or based from facts. Okay, so there is a study just released June 1 from the Lancet, which identified or studied physical distancing, wearing of face masks, and eye protection as a way of prevention the transmission of SARS-CoV-2. Okay, as we can see in this study, so we can see here, this is a forest plot on the effect of observance of physical distancing. So we can see here that it favors further distance in transmission of SARS-CoV-2. Okay, so this study actually showed that whenever we perform physical distancing for 1 meter, it decreases the chance of transmission to 12.8%. But when you exhibit more than 1 meter distance, the chance of transmission is actually lowered down to 2.6%. And aside from maintaining physical distancing, so it was mentioned also that wearing of face masks can contribute in the transmission of in the prevention of transmission of the virus. So without masks, you have the chance of transmitting the infection 17.4%. But whenever you wear face masks, okay, it is decreased to 3.1%. So face masks basically are for your eye protection. As I've mentioned a while ago, eyes is one of the portal of entries of the virus going to our body. So it has a rationale whenever we use face masks. And no, for eye protection. That's for face mask. For eye protection, so it is decreased from 16% to 5.5%. So aside from face mask, whenever we use face shield or goggles, so it is a form of eye protection. So it can contribute in the prevention of transmission of the virus. Thus, this study concluded that while there is no available, there are current studies on effective drugs and even current trials for the effective and safe vaccine against COVID-19. So what we can capitalize as of this time is this minimum public health measures. So namely, maintenance of physical distancing, wearing of face masks, and even eye protection. So other infection control measures, so we have to follow the standard precaution. Ano ba yung standard precaution? We always see it. Doctors order it's a chart, but what is your standard precautions? It's mainly observance of hand hygiene and respiratory etiquette. So I cannot overemphasize here that we should always perform hand washing and hand hygiene. Okay, so whether hand hygiene can be categorized as hand washing with soap and water whenever you have a visibly soiled hands, or use of alcohol-based hand rub, particularly with 70% alcohol. Okay, so it's very important to perform hand hygiene, okay, especially during this time. Okay, so there's a question, will wearing gloves protect me from getting COVID-19? So our recommendation here is that if you wear a glove, okay, if you want to wear gloves, it's okay, but it should not be an alternative or an excuse for you to perform hand hygiene. So whenever you wear gloves, you still have to perform regular hand washing, okay, or perform hand hygiene with alcohol-based hand rub. Okay, so another component of your standard precaution is observance of respiratory hygiene or cough etiquette. So whenever we cough or sneeze, we have to cover our mouth with bare hands, but after exposure to respiratory fluids, we have to perform hand hygiene again. Or whenever we use tissue, so we have to cover our mouth with tissue, we have to throw it sa trash bin and again perform hand hygiene. So this is very basic, but sometimes hindi pa rin napaperform kasi nai-ignore. But these are simple infection prevention control measures, but very effective, particularly in the transmission, in preventing the transmission of the virus. Okay, so going to the other forms of control measures, as I've mentioned a while ago, PPE. Okay, sometimes we overly rely on the use of PPE. Pag naka-PPE na, all the other measures are disregarded. But however, as I've shown to you, okay, so PPE actually is at the lowest part of the hierarchy of control already. So we have to aside from wearing proper or appropriate PPE, we still have to perform the standard infection prevention and control measures. And when we say appropriate PPE, so what is the meaning of appropriate or rational PPE? So the PPE should be dependent on the risk of getting the virus, meaning you have to check where you are assigned and to check the category of the area where you are assigned, because we have these low-risk areas. For example, OPD is considered as a low-risk area. You will have a different set of personal protective equipment for OPD setting as compared when you are in a higher risk area, such as directly taking care of COVID-19 patients, particularly those in the intensive care unit or those critically ill COVID-19 patients. So when you're taking care of a critically ill COVID-19 patient, you have a separate, entirely different set of PPE as compared when you are just in the outpatient clinic. So that is the appropriate or rational way of wearing PPE. Okay, so infection control, sabi nga nila, dapat tama lang sa infection control. Hindi under at hindi rin naman over. Okay, so infection control is always practical way and the appropriate way lang. Okay, so yung sinasabi nga nila, sakto lang for it to be effective. Okay, so for example, in the outpatient clinic, again going back to our guidelines, our recommendation is just to wear this minimum PPE in the outpatient clinic. The minimum PPE recommendation is actually a face mask and a face shield. So mask to cover your mouth and nose, and the shield, face shield or goggles actually for your eye protection. Because what's your risk of getting the virus in the outpatient? So it is lesser as compared when you're taking care of a COVID-19 positive, confirmed COVID-19 case. Okay. So speaking of masks, I just want to mention here, okay, still the rational use of PPE, so particularly involving N95 masks. Sometimes we are very obsessed in wearing N95 masks, even in the community or industry, we are wearing N95 masks. But I want to emphasize here the rational use of N95, because aside from the fact that there is only guidelines wherein you have to wear N95. It's important to use N95 mask. Okay, so soon.
Yes, Doc, you're clear naman po.
So just a background on N95 mask for the benefit of our residents. So theoretically, N95 masks are designed for airborne infections. However, whenever WHO or CDC declares a novel virus, okay, so kahit na droplets, sometimes na-elevate to airborne. So we have to protect ourselves. So N95 masks are ideally for airborne precautions. Thus, airborne infections. Thus, it should be reserved only to be used for airborne infections. So what are these airborne infections ba? TB, is an established airborne infection or is established to be transmitted via airborne. So pag we're dealing with TB patients, N95 talaga yan. However, for COVID-19, it should only be used whenever we are performing an aerosol generating procedure. Otherwise, if you're quite sure that you're not performing AGP, then it's not necessary or it's not a mandatory to use an N95 mask. And aside from that, I want to remind everyone that we should use a CDC and NIOSH certified N95. And again, I want to remind that your N95 should be fit tested to you, okay? Because sabi nga nila, if it does not fit, then it does not work, okay? I'm sure in our respective healthcare facilities, there is a fit testing for N95 that should be done. Okay? So sa mga residents, you have to check alin ba yung N95 that is fitted to you because it will serve best your purpose whenever you wear a fit-tested N95. So again, addressing the shortage of supplies in N95, I want to emphasize that N95 should be judiciously used because we are addressing this issue already of shortage of supplies of N95. However, CDC and even the IDSA or Infectious Disease Society of America tried to address this issue of shortage of N95 supplies already because of all the PPEs, N95, there's an issue of shortage mostly in N95. So that's why nowadays they recommend extended use and reuse of N95 already. Before kasi, di ba, ideally, one use, then you discard. However, we are in a pandemic situation already and we don't know up to when will this pandemic end. Then we have to judiciously use our N95. So nowadays, they recommend that you can extend the use of N95 maximum of 8 hours for continuous use. And it can only be reused, okay, if it is free from visible soiling and remains functional. Of course, if you have visibly soiled N95, kahit na 1 hour pa lang yan, you have to discard it already. However, kung yung normal duty lang naman natin, so as compared before na one-use discard, now it can be extended up to 8 hours. Okay, so maximum number of uses, they say, is up to four times that you can reuse the N95. And again, if you want to preserve your N95, it's recommended that you employ this engineering controls. You can use additional engineering controls, barriers like your face shield can protect your N95, or you can put an additional surgical mask on top of your N95 somehow to protect or to preserve the integrity of your N95. And then this should be kept in a clean, breathable container, okay, in between uses. So they recommend plastic or Ziploc, but experts say that when you have a moist N95, it should be placed in a paper bag. Kasi kapag moist sa plastic, then it can facilitate growth of other organisms, particularly bacteria. Okay, so pag medyo basa, avoid yung mga plastics where use brown bag, okay, yung mga brown bag, or even sometimes na-improvise yung paper bag. So your container should have proper identification para hindi nagkakapalit-palit for hygiene purposes. And again, whenever you use and reuse your N95, you should perform hand hygiene. Okay, parating hand hygiene, wag kakalimutan. Okay, here is the IDSA algorithm wherein even if you're performing aerosol generating procedure, they allow already the use or extended use of N95 and what we call as reprocessing. Okay, so reprocessing or decontamination of N95, I think almost all hospitals to address the shortage of N95 perform this already, diba? Kung before, one use only, discard, but now we can perform reprocessing or decontamination of N95. And this is an acceptable infection prevention and control strategy already. So there are different types of reprocessing of your N95, but they say that the most commonly or the best way of reprocessing is this VHP, or the vaporized hydrogen peroxide. So I just want to show everyone that this is the VHP. Okay, so VHP procedure wherein you have hydrogen peroxide decontaminating or reprocessing all those N95 if it is available in your facility. And they say that if this is performed, you can reuse that N95 up to 3 times. But as I've asked other hospitals, I think hindi gaanong na-utilize ang VHP. I don't know, maybe this is an expensive process. That's why they usually rely on UV. Okay, so UV radiation or UV irradiation of this N95 can reprocess or decontaminate your N95 mask. Again, after decontamination or reprocessing, it can be reused up to 3 times your N95. Okay? So, how about the issue of KN95? Yeah, maraming nagtatanong. Ideally, CDC, NIOSH recommend the use of N95. But again, we are in a pandemic situation already, so there are a lot of innovations. So KN95 was released. So we tried to look on the difference between KN95 and an N95, and studies showed that quality assured KN95 masks are actually comparable with your N95. So they are both respirators. They have the same purpose of filtering the air, okay? But the only difference is that KN95 has a total inward leakage of 8%, less than or equal to 8%, okay? So meaning it has still the tendency that the air can still enter you, as compared to N95, which supposed to be, if it's fit tested, has 0 TIL or total inward leakage. But other than that, it both has the capacity to filter more than or equal to 95% of the particles. So that's our recommendation regarding KN95. A fit-tested N95 mask still the recommendation for AGP. However, in crisis situations wherein N95 is not available, then a fit-tested, again, a fit-tested and a quality-assured KN95 mask should be used in lieu of this N95. Okay? So how about other PPEs? So still in the outpatient setting, if you are anticipating exposure to blood or body fluids, so you can add gloves or gown on top of your mask and your face shield as additional PPEs in your outpatient setting. So again, I want to emphasize here the rational and judicious use of PPE. So it will all depend on your risk category. Whenever, what area you are assigned, your PPE should be dependent on that. Okay, so other control measures, so engineering controls, I just want to show here this physical distancing, okay? And then how about issue on foot bath? So we see a lot of foot bath, shoe bath. Minsan ito yung nagiging sa mga establishments, their way of showing people that they are following these infection control measures. But as much as possible, we try to look for scientific evidence on directly correlating foot shoe bath in the prevention of COVID-19. There is still an insufficient evidence. Thus, we recommend that our recommendation regarding foot bath is there is no enough evidence to recommend the use of foot or shoe baths in the entry or exit sites in the outpatient clinic setting or in any establishment today. Okay, so far. But I think there are several studies, ongoing several studies already trying to support this measure. However, if you want to still use foot bath, you can still use it. However, you have to ensure that manufacturer's instructions are followed, especially regarding the contact time and frequency of replacement to ensure effectiveness of disinfection. Minsan kasi we observe, di ba, sa mga establishments, merong foot bath pero halos tuyo na. So maybe it was there 1 week ago. So it should be properly replaced, okay, and observed all the manufacturer's instructions. Okay, so another infection control measure, particularly in the context of COVID-19, parati nating naririnig, we have to maintain proper ventilation. Okay, so the purpose of ventilation is to provide healthy air for breathing by diluting the pollutants in the building and removing it. So proper ventilation is expressed, okay, ang unit of measure niya is via air change per hour or the air exchanges. Yung parati nating naririnig, air exchanges. And air exchanges or the air changes per hour pertains to the inflow air per unit time or the number of times the air goes in or is replaced, goes in a building and is replaced in an hour. And the recommendation, particularly if you have airborne infection, when you're dealing with an airborne infection, is 12 air exchanges, okay? However, for COVID-19, theoretically or strictly speaking, being it a respiratory droplet, so the minimum is 6 to 12, okay? So, paano ma-achieve tong air exchanges na to? So later on, I'll show some examples, but majority, we can ask our hospital engineers for us to compute for the 6 to 12 air exchanges per hour in a room. Okay, so this is a CDC recommendation wherein this is a study done in Hong Kong. So they tried to compare or to approximate the air exchanges if you have a naturally ventilated rooms, particularly in an outpatient clinic room. So naturally ventilated, meaning you have open windows in a room or open door. Okay, so as you can see here, when you have closed window, closed door in a single room, the achieved air changes per hour is only 0.6. However, when you open your door and your window, you can achieve an air exchange of 18.8 to 22.2, which is far beyond the 6 to 12 air exchanges recommendation for COVID-19. Or kahit na yung door nyo 50% open lang, but when you have open 50% open na door, but you have 50% opening din ng window, then you have air exchanges of 11.5. So still, aabot pa rin dun sa 12 air exchanges na recommendation for COVID-19. So even in a waiting room. How about when you're in a mechanically ventilated room? So mechanically ventilated meaning you have an exhaust fan. Okay, so I just want to show here in this table that when you have an exhaust fan in your room, and all the more when you open your door and your window, you have this much of air exchanges achieved. Okay, so nakakatulong talaga when you install exhaust fan. Okay, because you achieve a mechanically mechanically ventilated room whenever you have an exhaust fan. However, it's always, we have to be reminded that whenever we use exhaust fan, okay, it should be installed where room air can be directed away from populated areas. Of course, we don't want to put our exhaust fan towards the patients queuing in our outpatient clinics. So it should be away from populated areas. Okay, so we have to remember that exhaust fan can increase the room temperature. Ito, one of the common complaints is mainit talaga if you have exhaust fan and the noise it creates. Okay, so however, in instances wherein I believe there are conditions or situations wherein you cannot really open the door and the window in some clinics, wala talaga, and then installation of exhaust fan cannot be possible, it's not possible, then what should be done or what can be, what we can do is just to add HEPA filter. Okay, so speaking of HEPA filter, so HEPA meaning high efficiency particulate air filter, its main goal is to filter at least 99.95% of the circulating particles. Okay, so being a filter, it is designed to filter air with an additional benefit of improving the air quality. However, we want to emphasize here that HEPA filter will not increase the air exchanges. Okay, so it will not provide additional ventilation. Kaya minsan na misconception yun eh. So I cannot achieve proper ventilation, mag-install na lang ako ng HEPA filter. But actually, HEPA filter will not increase your ventilation, your air exchanges. But in instances na no choice talaga, you cannot increase the ventilation in your room, then at least somehow, parang better than nothing, you can install your HEPA filter so that you can ensure that the circulating air is more filtered as compared without having HEPA filter. Okay, so our recommendation, so HEPA filters provide additional benefit in improving the air quality circulating in your room whenever your adequate ventilation cannot be achieved. However, we have to ensure that the manufacturer's protocols are still followed, including configuration, maintenance, and replacement of the HEPA filters within the unit. So we have to read the manufacturer's instruction because sometimes it will all depend on the size of your room. Okay? Okay, so other engineering controls, so we have these physical barriers, acrylic barriers. So there is no problem whenever we use these acrylic barriers, but again, we have to rely mainly on proper use of PPE, and these acrylic barriers are just additional engineering controls. And what is important is that whenever we use these acrylic barriers, it should be properly cleaned and disinfected. Minsan kasi, lalagay lang ng plastic barriers, pero proper cleaning and disinfection is not observed. Okay, so what is important here is that you can use all of those acrylic barriers provided that you constantly clean and disinfect it. So speaking of cleaning and disinfection, so another important infection prevention control strategy is proper disinfection of our environment. Okay, so disinfection, it's not only disinfection, but also cleaning. So cleaning pertains to the removal of microbes, dirt, and impurities from the surfaces. Okay, it does not kill the microbes, but somehow it decreases the number of microbes on top of the surface. And when you apply chemicals that directly kill the microbes, that's proper disinfection. So SARS-CoV-2, so it's a virus, although it's a novel virus and it gave a lot of problem with us in terms of mortality and morbidity. To balance it out, it can easily be destroyed with proper cleaning and disinfection. So unlike your spores or your TB, which are difficult to kill microorganisms, viruses in general are easily killed, particularly with LLD or your low-level disinfection only. Okay, so to prove this, the recommended disinfectant for COVID-19 is just only a 70% ethyl alcohol, or we can use a disinfectant, the 1:10. So what they recommend is a 1:10 sodium hypochlorite or the usual household bleach. Okay, so magkano lang bang isang galon ng household bleach or this sodium hypochlorite? It's very cheap. And if we properly perform proper cleaning and disinfecting in our own households or in our own workplace, then we can prevent the transmission of the virus via contaminated surfaces. Okay, so just a reminder on proper disinfection, we have to prepare this bleach or disinfectant chlorine solution for 1 day only. Okay, so it has its expiration. So hindi tayo po pwedeng mag-prepare ng disinfectant good for 1 month. Okay, so we have to prepare for daily use of this disinfectant kasi nag-expire siya. So we have to prepare. Okay, so take note for our housekeeping, we have to prepare chlorine solution enough for a day use. Okay, and we have to follow the manufacturer's instruction again. Put a proper label when you prepare it and the date and time of expiration. Prepare in a well-ventilated room because this is a toxic chemical and can be toxic to those who prepare it. And you have to have a safety data sheet all the time. So topping up is not acceptable. So ano ba yung topping up? When you have, for example, may natira pang bleach for this day and then you just top up for preparation for tomorrow, so it's not acceptable. Again, as much as possible, you have to prepare only your chlorine solution for 1 day. Okay, so for tomorrow, you have to prepare another one. And double dipping of clothes is not recommended. If you can discard this cloth for this day, then you have to discard it already. Throw away disposable cleaning equipment. Okay? And what are the recommendations? So as much as possible, we have to disinfect the commonly touched surfaces or the high-touch surfaces. So these are the surfaces that are most commonly touched by people. So alin ba to? Your handles, light switches, sa sinks, okay, yung mga keyboards nyo, as compared to your low, less frequently touched surfaces. For example, your ceiling, your window, okay, your walls. Okay, kasi hindi naman po pwedeng araw-araw naglilinis tayo ng ceiling or ng window. So for those less frequently touched surfaces, the recommendation is to clean it periodically. However, for these commonly touched surfaces, the recommendation, particularly in the setting of outpatient, after every patient contact, if you perform or when you do outpatient cleaning. After every patient contact, you have to clean your tables and then your keyboards, or at the end of your cleaning. Okay? Okay, so just want to mention here that again, your sodium hypochlorite is a toxic chemical. Then you do not have, or it's not recommended that you spray it directly to the person to prevent COVID-19, and all the more drinking it. Sometimes ginagawang joke to. However, for lay people, it's very important to emphasize that we do not do this, because sometimes yung mga desperate to very fearful or anxious about COVID-19, they might take this seriously. So we should not do that. And actually, WHO released this announcement already that spraying or misting does not protect against COVID-19. Still, the main mode of disinfection is manual disinfection. So meaning manual, you clean the surfaces with cloth and then with your disinfectant, and you manually remove or clean the surfaces. Okay? So other forms of disinfection, UV. How about UV? Is it an effective way of disinfecting? So UVGI, or your ultraviolet germicidal irradiation, is considered as an adjunct to your manual disinfection as a form of disinfection for COVID-19. So particularly, we have to look for UVC or your ultraviolet C, and this can be obtained via portable UV disinfectants. There are a lot of UV sold in the market already. UV cabinets, UV sterilizers, even your UV air purifiers, and we even have these UV handheld devices. Again, we have to follow the manufacturer's instruction whenever we use UV, and we have to remember some precautionary measures about UV light. So UV, because exposure to UV can have some side effects like skin irritation and keratoconjunctivitis. That's why we have to follow these precautions and avoid looking straight into the light source. And skin and eye protection, if exposure, should be worn if exposure is unavailable. And we should never put UV whenever we are having a clinic or in a room wherein there is still a patient. Okay, so we have to clear the room first for any people before we start using UV. And also, we have to be reminded that this UV can produce ozone, thus causing cough, shortness of breath, exacerbations of lung diseases, dizziness, headache, and nasal irritation. So we just have to remind, or we have to take note of all of these precautionary measures whenever we use UV light. Okay, so our recommendations, it should not be used directly for your hands and your skin to disinfect your hands and skin. And this is only an adjunct or an addition to your manual disinfection. And we have to ensure that we should follow the manufacturer's recommendation and follow the safety precautions. Okay, so other aspects of infection control, waste management, whenever all waste associated with COVID-19 patients should be considered as infectious waste. We have to follow segregation, okay, and avoid this one. And they should be properly treated, okay. When we have this infectious waste, hospital waste should be properly treated. How about laundry? So linen of our COVID-19 patients. So it should be bagged. We should avoid sorting to prevent further spread of possible airborne particles. We can do machine wash or hand wash. So the recommendation is soak linen in hot water and detergent, drain, and then add additional disinfectant such as chlorine. Okay, so I think during this time, patients with suspect or confirmed COVID-19 require our care, but we should not forget that there are other patients aside from COVID-19 that still need our help and our medical care and medical attention. So we have to protect ourselves so that we can continuously serve whether COVID or non-COVID patients. And during this COVID-19 pandemic time or era, we should always remember this minimum public health measures. Hand washing, hand washing, hand washing. So makulitan na kayo, but still hand washing pa rin in the end. So proper masking, okay, universal masking, and proper or appropriate use of PPE, maintenance of physical distancing, and we have all of these adjunctive strategies with the use of HEPA filter and ultraviolet germicidal irradiation, and proper cleaning and disinfection. So again, physical distancing, okay? So mga Pinoy, di ba, we are very used to beso-beso. Minsan nga yun, kaya one reason bakit nakakalimot. Oo. But during this COVID-19, we have to get used to this other way of greeting daw our fellow Filipinos. So can use a wave, nod, or a bow, or meron yung mabuhay wave, and avoid beso muna and kissing to maintain physical distance. Always wear mask, okay? Because studies show that when an infected person is wearing a mask and you are susceptible host is wearing a mask too, both of you are wearing masks, then the transmission probability is greatly decreased as compared when we do not wear masks. But again, proper wear of mask. It's not just you wear mask, but you have to properly wear the mask. And again, cannot overemphasize hand hygiene. Okay, so these are the basic strategies, whether you're inside the hospital, at homes, in the community, so all basic protection strategies are the same. Okay, so I think that's, I've answered all my objectives, epidemiology, the transmission, the available diagnostic tests, and mainly on the infection prevention and control measures for COVID-19. So I just want to share here. So sabi nga nila, matagal-tagal pa ang laban. So, but we have these lessons already from COVID-19 and we have to continue this. So life is short, jobs are temporary, health is wealth, but in the end, we need to survive. Okay, so together we will lead this fight against COVID-19. Thank you.
Thank you very much, Dr. Rojas, for that very comprehensive lecture regarding COVID-19 and how we can prevent that in our work setting. Now we will be entertaining the questions that you have posted in our chat box and in our Facebook group right now. Actually, we would like to acknowledge the 100, almost 150 at most, 150 viewers that we have in our Facebook broadcast. I think most of them are our nurses, our other consultants, and other residents from the different departments of Ospital ng Maynila. Although we've been seeing also comments from our alumni and some guests from outside of Ospital ng Maynila. But Doctora, thank you for that. Let me start the question. There's this particular question, Doctora, from one of our staff, I think, or clerk. Good morning, Dr. Rojas. Ask ko lang po, what's your comment regarding using of aircon in COVID patients' rooms? I know po that the best is for the room to be well ventilated or negative pressure that we don't have right now in OM. But does the aircon recirculates the air and the virus in the room?
Okay, so thank you also. So ideally, di ba, for airborne, actually for airborne infections, the ideal is a negative pressure. However, CDC, even CDC recognized it that it's not necessary to be hard and fast rule that negative pressure only. So I've shown to you the recommendation how we can achieve proper ventilation in a room. So you just open the windows and you just open the door. That's the best way of natural ventilation. Now, regarding aircon, so I receive a lot of questions that kasi iinitan ng mga doktor pag walang aircon. So actually, pero magagalit sa akin ng mga engineer, magagalit sa amin. So you can open you can turn on your aircon as long as you have an exhaust fan, or you can still maintain open your window. Kaya lang mga engineers, ayaw nila. Kasi I think this is not acceptable. So if, as much as possible, if you can avoid turning on your aircon, tiis-tiis, no? Tiis-tiis with natural ventilation, then that's the best way. Pero kung hindi, pwede naman i-open nyo as long as you can still maintain proper ventilation. You have an exhaust fan, or yun nga, you will open your window.
Okay. Thank you po, Doktora. Another question po is from the same person. Clarify lang po if we know that nebulization is an aerosol generating procedure. Some doctors are hesitant po kasi in using them to patients. So what can you comment about that daw po, Doktora?
So I think we have our pulmo consultants here. So in general, so if we can avoid nebulization and all of these aerosol generating procedures, we avoid it. So during this COVID time, kung pwedeng yung puff na lang muna, hindi mag-nebulize. So we prefer that over nebulization.
Okay, from one of our residents, ma'am, it was mentioned a while ago that the virus can stay up to 4 to 5 days in paper. Is it advisable that COVID ward charts are disinfected with spore clear prior to taking them out of the ward, especially when patients are discharged?
Sige. So in some hospitals kasi, di ba, they advocate the use of electronic already. However, in situations wherein you cannot perform this, so we have to adjust with the situation. Yun nga, I've mentioned a while ago, yung essence nung showing the viability of the virus on these different surfaces is that to show that these viruses can remain viable on those surfaces, but if it is properly cleaned and disinfected naman, then it should not be an issue. However, kung paper, mahirap naman basahin yung paper, no? So the best advice that we can have for that is that you perform hand hygiene, okay, whenever you touch these surfaces. Kasi it's an indirect way of getting the virus, and your only conduit wherein the virus can enter your body is via your hands. So, kung hindi nyo ma-prevent na matouch all those charts of our patient, but kung pwedeng hindi na nga mag-paperless na, if that will be allowed in our hospital, that's better. But if hindi ma-avoid ang paperless, touching all of these documents, then you should always perform hand hygiene. Okay? Kasi kahit na na-touch mo yung surface, but you remove the virus from your hands, and then you touch it. Very important also that you don't touch your mouth, your nose, and your eyes during your tour of duty, then it cannot be transmitted. So minsan kasi napipiloso po But we have to understand, again, you have to understand the mode of transmission of the virus so that you can react practically rin and rational also.
Yes. I think this question is much more applicable to us kasi you mentioned earlier, Doctora, that